Greetings, everyone, and thank you for being here today for this DNP project presentation. I'd like to discuss an issue that is important to me. I think health promotion and maintenance should be a significant focus of healthcare, as it is a more proactive approach to improving population health, improving the quality of life of Americans, and also reducing the cost of care, which, as we all know, healthcare consumes a large percentage of our GDP, actually robbing other industries of financial resources. Now, this is a project that I did a few years ago. I did present it initially at a conference in Indiana, and I would like to present it to you, and hopefully you will like what I have to say. Hmm. So the purpose of this health promotion project was to develop and implement an evidence-based educational intervention aimed at increasing the proportion of African American men who would commit to participating in prostate cancer screening discussions with a healthcare provider. As far as project objectives, participants will state the latest prostate cancer screening requirements recommended by the U.S. Preventive Task Force. And also, participants will name one ethnic group with the highest risk of developing late stage prostate cancer. As far as the background, prostate cancer is the most common cancer amongst men after skin cancer. The United States Preventive Task Force, Service Task Force, has recommended new screening guidelines since the year 2017, and I believe those guidelines have since changed. Low levels of prostate cancer screening place African American men at risk for developing a late stage diagnosis and subsequent painful metastatic um, disease, such as bone cancer, which is the example I've given here. And African American men have a greater chance of being diagnosed with prostate cancer compared to any other ethnic group. Now, my PICO clinical question: will an educational intervention that focuses on the importance of early prostate cancer screenings for African American men 45 years and older, which was the intervention group, increase participation rates in terms of prostate screening, shared decision making discussions, compared to the usual care group within a 6 month period of time? All right. So essentially, what I wanted to know is after the educational intervention, I wanted to know if the intervention group would commit to having a shared decision-making discussion with the healthcare provider within 6 months compared to the control group. Now, my problem statement, according to Shanoy et al., it was indicated that the rate of incidence for African American men developing prostate cancer is 60% higher, and the mortality rate is 2 to 3 times more than Caucasian men. Now, the framework that was used to develop this project was the framework developed by Nola Pender, the health promotion model. It underpins this project and was used as a guide in its development. This model focuses on health promotion and prevention. It enhances health by motivating behavior, which is different from the health belief model, which uses fear. And of course, the advantage of motivating behavior versus fear is that the behavior tends to be more consistent over time. It also focuses on the biopsychosocial dimensions or that whole person. And also, this health promotion model um, is useful in secondary prevention after someone has developed a disease, but we're still trying to maintain a certain level of health. Doesn't mean you just throw in a towel, in other words. As far as the literature review, um, according to Drake, um, a uh, a feasibility study was developed and pilot tested an intervention to increase knowledge about prostate cancer screening and to promote self-efficacy to participate in the informed decision-making process. According to Ross et al., a community-based participatory research um, is becoming one of the dominant approaches for bringing evidence-based and consensus-based cancer prevention and control practices to the medically underserved populations. This paper describes a collaborative process for linking inner city um, African American men to free prostate cancer education, physician counseling, and screening opportunities, such as the PSA lab test, as well as the digital rectal examination or DRE. As far as settings and methods, there were two predominantly African American local community parishes. Out of one group, the intervention group, there were 16 participants. In the control group, there were 17 participants, and they were African American men, 45 years and older. The method that was used, it was a quasi-experimental and a pre and post-test design, and also a convenience sample was taken. So it was a pretty much a mixture. There was also a demographic survey. There was on-site prostate cancer educational intervention, particularly with the intervention group, and evaluation of the intervention group took place as well. As far as the control group, I just basically provided them with a tip sheet regarding conditions that mostly impact African Americans because I felt like I wanted them to learn something or to take away something from this project. And so I created a tip sheet containing information about prostate and colorectal cancer and diabetes. And the control group was blinded to the study's purpose. So a questionnaire was found in a journal that was written by Winrich, as it helped to identify participants' knowledge level, health beliefs, and practices related to the screening and early detection of prostate cancer in African American men. Now, the pretest was used to determine baseline information on participants' knowledge regarding prostate cancer and screenings. The assessment test consisted of a total of 14 true and false questions. The pre-test and post-test consisted of the same written content. The test, the tool rather, does have a Cronbach Alpha 0.84, which is a reliable tool for assessing the group's knowledge. If the members missed more than two questions on the pretest, this was deemed not a passing score. As far as results are concerned, I did use descriptive statistics. A series of chi-square and t-tests was performed to determine differences between the groups. We did look at demographic characteristics such as age, education, social class, marital status, insurance and family history, and more, of course. And the chi-square and t-test did not or failed to achieve any statistical significance between the two groups. All right. Now, the intervention group, as far as the pretest is concerned, scored 71.988 with a standard deviation of just over 12. As far as the post test is concerned, the intervention group scored 82.681. And so there was a moderate increase, and I was pretty happy with that. At least I moved in a positive direction, if you will. All right. Now, in my article, in Table 1, it reports the descriptive statistics associated with this analysis. These results show that individuals in the intervention group were significantly more likely to plan to screen within the next 6 months. And that was 81.3%, compared to the control group at 35.3%. For the outcome measure, a 20% difference was set as the target goal, as you can see here. In particular, the proportion of men in the experimental group who plan to speak with a healthcare provider about prostate cancer screenings within 6 months following the educational intervention would be at least 20% or more compared to the control group. And the goal was certainly met here. Right. There was also an evaluation survey that was performed. Um, that was performed, and I've already given you information in terms of um, the. Well, let me back up. So the goal of 20% um, was decided for this intervention, and an evaluation survey was provided to the group. And in the intervention group, those who are likely to have a shared decision-making discussion for screening within the next 6 months was about 81%, and and the control group, it was 35.3%. And so that was a pretty significant difference between the two groups. All right. As far as discussion is concerned, limitations in particular, um, the part of the limitations was that it was a small sample size in both the intervention and control group. So as far as generalizability issues, that could be problematic. There was no power analysis done as a result of the small sample size. Um, um, we need um, we need a randomized studies because this represents the target population and also eliminates sampling bias. And so that was also um, a limitation. There were also competing events during the health fair. The health fair for the intervention group. The pastor for the parish had admonished the group to make sure they participated in each of the booths, health booths that were set up, and so that pretty much took some of the attention away from what we were doing because we were actually situated in the auditorium inside the parish, but they were kind of going in and out, and so that was a bit of a problem. So anyway, there was also some visual impairment issues, so it made it difficult for some members to fill out the information, and so a family member of mine actually assisted me with this, and so um, I wish I had um, um, accounted for this by bringing more, maybe a couple of more nurses, if you will. As far as recommendations is concerned, um, I feel a lot more time for complex health promotion programs with marginalized groups is essential. Um, we also need to increase the sample size, and perhaps we can do that by involving the community, maybe putting up flyers and asking the pastor, whichever um, medium they use to reach out to the community to participate in the fair during that time. Um, as far as I also recommend replicating the study in these at-risk, marginalized communities, and also to instruct clients to bring their reading glasses with them, and that would make things go a little easier. As far as implications for practice, prostate cancer screenings can reduce cancer-related morbidity and mortality. Nurses also can facilitate that shared decision making by providing relevant information when discussing prostate cancer screenings with their patients. Also, um, um, it was important to understand the benefits and risk of screenings, and also health promotion activities in the community can improve the image of nurses to the public. In conclusion, the data shows that African American men are at risk, at significant risk, for a late stage diagnosis of prostate cancer. The literature is replete with data showing effectiveness, showing the effectiveness of health education interventions. Um, um, I was able to identify an at risk group in the community, and also the efficacy of a prostate cancer educational intervention certainly um, uh, appeared to show some value. And of course, the DNP project was used as an exemplar for other health promotion programs to hopefully be implemented in the future. These are my references here, and that is about it. And I really thank everyone for participating in this presentation.